Dr. Ohman is Professor of Cardiovascular Medicine and the Kent and Siri Rawson Director of the Duke Program for Advanced Coronary Disease, Associate Director of the Duke Heart Center at Duke University Medical Center and Duke Clinical Research Institute. So we're pleased to have you present today. Please help me welcome Dr. Ohman.
Thank you, Subin. It's great to give this talk to all of you. This has been a little bit of a passion of mine for the last several years, and I hope to share with you some personal experience along with some science behind this. These are my disclosures for this. As you can see, there are actually no device companies here listed. So I'm going to try to cover 4 broad areas. I'm going to give you a little bit of a historic perspective of where we've been with PCI for left main disease. I call that the no-go area, and you will understand that pretty quickly when you see the slides. After that, I'm going to talk a little bit about the tools that were developed that made it possible to tackle this more complex type of patient. I'm going to give you an update on what evidence we have for PCI for left main, and also share with you a little bit of what the guidelines and appropriateness criteria say. And then the final few minutes, I'm going to expand on where I think things might go in the future and where we are sort of leaning into here pretty quickly. I'm actually fairly grateful that there's no surgeon here yet, but hopefully that will come. Before I get into my talk, I want to give credit to a number of people. Obviously, Dr. Greenfield, who extensively hired these 3 gentlemen who really were formative in my career. And they gave me some real interesting ideas of how to go forward. Richard Stack was the former director of the interventional program here at Duke. He's an inventor. You all know Harry Phillips and Rob Califf. So they sort of collectively gave me a lot of ideas. One of them, think outside the box, and I'll share with you some of the things that have come up in this regards. Communicate the risk of this high-risk procedure, both with patient and family, but also with a primary physician. Collect and aggregate the data, and when in doubt, randomize. And I'm going to let you guess who actually came up with those different statements. So PCI, or interventional cardiology, has really had a tremendous change in the United States or worldwide over the last 2 decades. This is a slide that actually gives the idea how open heart surgery, number of procedures, bypass surgery, as well as PCI. And what you can see here is fairly interesting. PCI was first developed in the late 70s, really didn't take off until the mid-80s, and then there was a big jump in the mid-90s, mostly related to the availability of stents that made this a much more reproducible type of procedure. You can see that bypass surgery in pink hasn't really increased that much. It actually sort of stabilized in the mid-90s and have been on a slightly downward trajectory since that time. PCI has got much more safe. This is actually from NCDR, published a few years ago now, looking at the outcomes in the last sort of 6 or 7 years for a PCI among different age groups. And you can see that for patients coming for elective PCI who are relatively young, we're looking at a 0.1 to 0.2% mortality. Now the elderly is a different ball game altogether. They still have a 3 to 4-fold higher risk of peri-procedure mortality. And obviously much of the patients that we see with left main disease tend to be elderly, as you can imagine. If you look at procedural success, and this is data now from Mayo Clinic, it's actually from the 70s, 90s, and onwards, it's become a very successful procedure overall, 94 to 96% overall success. And emergency CABG, that used to be the bane of this procedure in the 80s and early 90s, have just about vanished. And as you know, elective procedures can now be done without backup surgery. So let's just turn back to left main disease for a little bit. Dr. Andreas Grunzig actually performed a plain balloon angioplasty, or POBA, for an unprotected left main in the early 1980s. It was a technical success, but the patient actually died, I think, within 6 months. Credit should be given to Jeff Hartzler at Mid-America Heart Institute. He actually forged ahead in the United States and published a series in 1989 on balloon angioplasty for left main disease. He really tried the hardest to make this a successful procedure, but it was a 64% 3-year mortality for these selected patients. And then finally, Steve Ellis at Cleveland Clinic published a multi-center registry of 107 patients in 1997 with a 10.6% 6-month mortality, quite a bit higher than what I showed you on the earlier slide. So my first experience with this is unforgettable. It wasn't quite hard for me to actually find this patient in the Duke medical records, but it was a 39-year-old female who presented with sudden cardiac arrest, BF, in Burlington. She had CPR, no ST elevation, and she was life flighted to Duke. She arrives in the cath lab in those days that used to be next to the emergency department, and she codes again. With me on call was Dr. Wayne Batchelor, a fellow that some of you will remember. And I remember he said to me after he finished the diagnostic angiogram, left main is missing, RCA is normal. On closer scrutiny, however, it was 100% left main, and it was thrombosed. So we did what we thought was the right thing, was to do a plain old balloon angioplasty of the left main. We got a decent result, nothing to be proud of. In fact, I'm quite happy that the films are long gone. But the patient then went to Cabbage the next morning, this was early hours in the morning, on a balloon pump with Dr. Dwayne Davis. She gets a Cabbage with Lima to the LAD, vein graft to the second marginal, with prolonged hospitalization, about 30 days in hospital. She finally gets discharged, seen in the clinic with mild heart failure, class 2, echo EF 25%, no angina. And I remind you, this is in 1996, so medical therapy, a lot of things weren't quite as they are today, but at least that's what happened. She was readmitted 9 months later with angina, and I'm paged by Dr. Vic Bihar, that some of you will remember, asked me why I sent the patient to bypass surgery. And I must admit, I was shocked. I had no idea. I said, I thought it was the right thing to do. Well, he said, the cath actually showed that left main was normal, so you should have just left her. She would have done well. And she did have a patent Lima, and 100, the vein graft to the second marginal was 100%. So it made me think, there may be something here that we haven't been able to figure out, but that we might want to work on in the future. Patient lived actually for almost 10 years after this procedure, and she died in 2004 of heart failure. So left main then is an interesting disease because it's a very short vessel. It has LAD and circumflex typically coming off after it, and fairly severe angles shown on this CTA, as you can see. Overall, narrowing over 50% occurs in about 4 to 6% of patients who undergo coronary angiograms. Most patients are symptomatic, and there are very high risk for cardiovascular events. If you occlude this vessel, it usually affects 75% of your left ventricle, and therefore untreated left main stenosis has over a 20% mortality at 1 year. So it's a highly lethal disease. Left main comes in different types, and I'm showing you 3 representations here. Up on the left-hand side is the ostial disease, just narrowing coming off the aorta. You have on the right-hand side distal bifurcation type of disease, which involves not only the left main, but also ostium, LAD, and circumflex. And then much more rare at the bottom is basically shaft disease with an isolated stenosis in the left main. So what are the tools that made all this possible? Well, I'm going to go through some of these. Drug-eluting stents were a major advance in this field, particularly when it comes to advanced branch stenting that I will share with you. Intravascular ultrasound allowed us an incredible opportunity to look inside the vessel and see what we were doing. So it actually made a huge difference. And then some other diagnostic tools that gets into looking at the amount of flow in the vessel as we were doing the work. And this is fractional flow reserve, and I'll explain that a little bit later. And this is very important when you do serial lesions. And then finally, the adequate hemodynamic support that actually is very helpful for complex patients with single patent vessel or severe LV dysfunction. So drug-eluting stents, as I alluded to, really has made a big difference. This is actually a series published some years ago, small numbers of patients here. But you can see that the overall restenosis rate with drug-eluting stents is 7.9%. It used to be about 30 to 40% in regular stents. And what you can see here with bare metal stents is still very high. And basically, bare metal stents should probably not be used in the left main because of the high restenosis rate. And it is interesting when you look at the impact of drug-eluting stents on left main. This is now a summary on 44 studies, 10,000 patients. It is actually associated with lower mortality, less myocardial infarction, and obviously much less target revascularization. It's not zero, but it is a lot lower. So drug-eluting stents allowed us to go forward and working more in this particular lesion. Now, what about ultrasound? Well, this is an ultrasound image that is a cross-sectional. On this side, this is the cross-sectional of the vessel. This is a longitudinal cut as the catheter is pulled back. And what you can see here, you can see all kinds of interesting things inside. You can see here, these are the lumen in here, and you can see there's a green and a blue area. These are the areas from different locations that we're able to superimpose and therefore figure out exactly how big a stent should be and how we should deploy it. On the right-hand side, you will also see here a wire which is actually in another vessel. And you can see an opening here, which is actually the opening into the circumflex in this area. This represents calcium with some blackout effect. If you look at the longitudinal image here, you can actually see the left main is down here, LAD is here, and here is your circumflex. And you can actually see exactly how much you have in distances when you place a stent when you use the IVUS for this type of setting. The one problem with left main disease is that the ostium of the left main is narrowed and our catheters go into the ostium. So sometimes we need to actually bracket our left main catheter, or the guide catheter, to sit outside. And here's an example of this where a wire is placed in the aortic cusp, preventing the guide to go in and therefore allowing the entire left main to be imaged in such a way that you can define exactly how long the left main is and how big it is at the ostium. This was a technique that actually a physician by the name of Walter Tan taught me some years ago, and I'll give him credit a little bit later on. There's another real advantage with intravascular ultrasound is actually shown on this slide. This is a pre-stenting image on the left-hand side of the LAD going upwards here. This arrow won't work here. This is the left main, this is the LAD, and this is circumflex. So this actually goes down the circumflex. This is the IVUS catheter. This is pre-stenting, and you can see there's a narrowing here. After stent is placed, you can see the small dots here into the proximal LAD. You have a shift of plaque moving into the circumflex. This would be almost impossible to tell, unless it was really bad, when you actually do an angiogram. But you can really easily see this with the IVUS as you pull the catheter back and this appears over this area. Another major advantage of ultrasound is the fact that you can actually see that if you have incompletely placed a stent, size is hard to tell in the left main. You get this open space behind the stent and the vessel wall on top, and you post-dilate that to get a very nice overall result. We even know now that if the vessel has a certain diameter here, left main has an area of about 8.2 millimeters, the restenosis rate is very low, and we can then extend that into the carina as well as the circumflex and the LAD. And you want to see here that the LAD area tends to be larger than the circumflex artery, making it a more important vessel in humans. Is this IVUS important? Well, there's actually an observational series from South Korea. C.J. Park published this a few years ago, looking at the mortality if you used IVUS versus no IVUS in left main stenting, and you can see there is a difference favoring using routine IVUS for this setting. Now, what about fractional flow reserve and the assessment of importance of serial lesions in the LAD and left main. So what is fractional flow reserve? Well, it is the maximal myocardial blood flow in the presence of a stenosis divided by a normal maximal blood flow. And the maximal blood flow is achieved by inducing hyperemia in the patient using adenosine. So you get a ratio, and we have studies that have told us that for vessels, a ratio below 0.8 would indicate lack of blood flow and therefore predominant ischemia. I'm not going to have time to go into those studies in detail, but here is just an example of how this looks for us in practical terms. And the red is represented the waveform in the proximal vessel prior to the lesion, and then with the wire, the pressure in distal to the lesion, and you can see that there is a difference here. There is a lower pressure indicating a fractional flow reserve of 0.75, which would indicate that the lesion is significant and should be treated. Now, how do we use this in practical terms? Well, we typically place a wire in a vessel, and we can then measure the fractional flow reserve. Distal to these two lesions is 0.6, which would indicate it's severe ischemia, potentially, and therefore you need to treat them. But you can see if you just measured here, in between the two lesions, you get an artificially high fractional flow reserve that once the vessel is treated distally and you get better runoff, you actually get a normal fractional flow reserve. So this is actually very useful for us as we define exactly how far we should treat these vessels. Furthermore, we get a lot of intermediate lesions in the cath lab. Here are two cases, A and B. These are actually from a publication in Circulation a few years ago by some colleagues from Holland. What you see here, each arrow represents a lesion. And I would just be interested in a show of hands. How many of you actually think lesion A is significant? Maybe you raise a hand here. A few. Okay. How about lesion C? Even less. Okay. All right. Well, the answer with fractional flow reserve is actually shown below here. It turns out that all of you who hedge your bets by not answering the question were actually somewhat correct in the sense that you're not going to make up your mind without fractional flow reserve. But you can actually see here on the right-hand side, this is the lesion that is significant by fractional flow reserve, 0.68, which would indicate ischemia, whereas the one on the left is 0.89. It turns out that when we review angiograms for left main disease, it's very hard for us to figure out if they're significant or non-significant. This is from the same paper by these colleagues that basically showed that angiographic reading as significant versus non-significant is the perfect scattergram by both reviewers, which would indicate why we would need an objective physiological parameter to be measured in the cath lab to give us guidance here. Now, this actually comes as an interesting twist for me, because one of my first projects as a fellow here at Duke was to do angiographic interpretation with very famous readers of angioplasty at the time. And I went around the country and showed them pictures. And when they reread their own films, the kappa statistics was 0.62 for figuring out if it was significance, which is just slightly better flipping a coin. Now, I never published that paper, at least not in my early stage of my career, but just to be sure that Dr. Cale, if he was here, I did publish it in 2008, some 12 years after the observation, figuring that I could survive that criticism. I had tenure, you're right. Well, so I've given you two avenues, right? Fractional flow reserve and IVUS. Now you can really combine both. And here is, this is from CJ Park in Korea, just showing nice illustrations of an ostial left main read at 60% visually, fairly smallish area, and a fractional flow reserve that's fairly reasonable. So you might be concerned that this could do well with medical therapy. On the other hand, this lesion here, read as 20%, of course I can't judge that, had an area that's just on the cusp of being okay, but has a lowish fractional flow reserve, suggesting that maybe using both is very advantageous. Now, it's very clear that if you have a fractional flow reserve less than 0.8, and the area is small. This is easy to decide, and it's easy to decide over here. The hard part is in this sort of middle area when both are borderline. And obviously, this is where more work needs to be done in the future, but it is allowing you to very clearly define what you're doing. So here I'm going to show you a case that we actually did last week, which is a gentleman who is in his 40s, who comes in with a distal left main lesion here, osteal LAD and circumflex, and this is how we approach this, which would be a culotte technique, which means one wire here in the LAD and another one in the circumflex over here. The way we approach this is we usually dilate the first time into the LAD with the wire. You see the wire is still here in the circumflex in case this vessel goes down. Then we turn around, same balloon, and go into the circumflex and dilate this, both in the left main into the circumflex, leaving the wires alone. And then after that, we place a stent into the circumflex here. Now you're going to see we're crossing over the LAD here, but the stent goes from here to here, roughly. And we have the wire left behind here, the LAD wire, ready to cross, which we do after the stent has been placed. And then we place an IVUS down here. Now, if you look inside here now, you can actually now see that we have the LAD wire here, we have the cross-sectional after dilatation in here, and we can actually now measure exact the diameters here of the vessels. In this particular, the blue is the left main, and the circumflex is the smaller vessel here of 2.2 millimeters cross-sectional area. And when you pull this back a little bit further, you can see that the now left main is much larger. So you need to actually stretch your stents that you place to fit this area. And this is going to be about 3.6 to 3.8 millimeters in diameter. And using this technique, we then go back and we put a stent through the other stent into the LAD. And then we rewire this. So now we have stent this way, and this is called culotte, or the French pants, by the way, for those of you who are fashion inclined, that actually are short French pants to boot. And then we come back and we actually put two balloons in here now that kiss each other into both directions, one this way and one the other way, and we're left with this final result here. And just to give you a visual, this is pre and this is post. This is all possible because you can do this with drug-eluting stent without causing a lot of hyperemia and causing a lot of restenosis. I just wanted to say one thing is that culotting, which is a type of treating bifurcation lesion, is just one of several techniques, including crush and T-stent. I'm not going to get into those. But what's really fascinating to me is that it's actually better to keep it as simple as possible. And in fact, this randomized trial, two randomized trials together of nearly 1,000 patients, showed very nicely that if you want to reduce events, as shown on the lower left-hand side, that actually keeping it simple, it turns out to be better as far as death MI and target vessel revascularization. Now, what about acute hemodynamic support? Well, we've been fortunate here over the years that have been able to work on this in our lab. Just to give you an idea, though, why this is so important. This is now from Walter Tan, the guy who taught me the wire technique. He published a paper in early 2000 that looked at a multi-center registry of left main PCI, unprotected, 279 patients, 24% mortality, death in MI cabbage 35%, so high event rate. But look at the things that drive the outcomes. Low EF, MR, obviously heart failure or shock, creatinine, and severe lesion calcification. These 5 variables really drive 80% of the mortality. So we tend to use LV support in these, where there's heart failure, MR, or low EF, to support the patient during the procedure. Most of you are familiar with the balloon pump, but for those of you who started your fellowship not knowing what it is a catheter that's placed in the distal aorta, inflates and deflates with a cardiac cycle, and by doing so causes diastolic inflation, which increases diastolic blood pressure and mean blood pressure and enhances coronary perfusion. During the deflation, it causes offload reduction, reduces LV wall tension. We have very little randomized trial data for elective PCI, but this is one study that has been completed. It's just published now a few months ago, and Dr. Vavali wrote a very nice editorial relating to this trial. But they randomized patients to balloon pump versus no balloon pump for elective PCI, and the patients who had the balloon pump actually turned out to have a lower mortality coming up to 5 years after the procedure, favoring a more elective use of the device to support the patient during high-risk PCI. Another device that we've used a lot is the Impella device, which is this device here, placed in the LV. There's a motor here that actually generates cardiac output. Blood goes in here, comes out into the aorta, continuous flow up to 2.5 liters per minute. This has been studied in one study that Dr. Manesh Patel was part of, and this is the outcome from that trial. PROTECT 2 trial, intention to treat, balloon pump versus Impella for high-risk PCI, very sick patients. You can see for intent to treat a trend to significant benefit per protocol, which excluded some patients who never got the device. There was a significant benefit in the composite endpoint favoring the Impella device. What about the evidence for PCI of left main guidelines and appropriate criteria? Well, before we get into that, might be useful to give an update on where left main PCI stands in the United States. And Matt Brennan, I don't know if he's here, but he published his paper last summer, which is a sort of snapshot of US practice. So it turns out it's quite rare. 4.5% of all PCIs are left main PCIs. You can see here that the case volume as far as detecting left main disease has fallen a little bit as prevention is taking hold, and the blue line at the very bottom of that is the rate of left main PCI, which is very low and stable. Now, if you look at how the patients that are treated with left main PCI, the majority are elective patients who receive drug-eluting stents. This is the blue line here. Very few emergency cases, very few cases with bare metal stent. And if anything, this elective use have gone up a little bit over the last several years, but this is a very small change. Now, in this series from the NCDR that Matt published, he actually examined the 30 months follow-up mortality, which was 43%. It's very high. Now, this, you should remember, is the Medicare population only, so it's a little bit higher. But what's interesting in his registry is that some of the things we pointed out, namely that drug-eluting stents is better, is shown here for mortality, that bifurcations are the most complex, showing a higher mortality in this series. So this just gives you the snapshot use practice. What about European practice? Well, there's one paper from the GRACE registry. This is an ACS registry, so this includes patients with ST elevation and cardiogenic shock, etc. But what you can see here is fairly interesting. From 2000 to 2007, the use of unprotected left main PCI has gone up during this period, whereas surgery has gone down. This is quite different from the United States that I'll show you. And importantly, mortality post-discharge to 6 months was lower with both PCI and CABG compared with the medical therapy alone strategy in this setting. What about randomized trial? Many of you saw this small trial published 2 years ago from Korea that looked at this. And actually, if you combine all the 4 randomized trials, 1,600 patients, 1-year outcomes for death, MI, stroke, repeat revascularization, you can see that it's a mixed picture. Mortality is about the same. MI is about the same. Stroke favors PCI. On the other hand, repeat revascularization favors CABG. That is to say, restenosis is still an issue. So there's really a mixed picture here, but overall, no major difference. But one of the studies found, the Syntax trial, they actually looked at the degree of stenosis in other vessels and categorized them by a score called the Syntax score. The higher the Syntax score, the more other vessel disease. And what you can see here in the lower subsets, less than 22 or 22 to 32, the Syntax score with less disease, actually the therapies look fairly comparable for death, MI, stroke, and urgent revascularization. Whereas for the really high-risk patients, CABG is still a winner overall in this left main cohort. Update this data to 3 years, and you can see that the mortality at 3 years in the Syntax trial for left main disease is about the same. Stroke is lower with PCI, MI is the same, death MI stroke the same, revasc higher. And now, just reported a few months ago, the left main subset up to 5 year. So for the lower end of the risk spectrum, this actually may be a reasonable strategy. Now, what about registries other than the trials that I've talked to you about? Well, there's actually quite a few registries published now. These are all shown here. And what you can see here, there's nearly 3,000 patients, all observational data. Odds ratio actually favors left main stenting here, but I want to point out heterogeneity is significant, which means that there's publication bias in these trials. So there's some publication bias favoring PCI. And when you look at death and MI and stroke, the same issue comes up. We have favorable with left main PCI, but once again, heterogeneity in these trials. Where there is no heterogeneity is the risk for repeat revascularization, which is significantly higher with left main stenting in all of these registries. There's one group of patients, though, that are interesting and that I think of some value here, and that is the elderly. Many of the elderly are at really high risk for bypass surgery. And this part of an Italian registry actually looked at this. This is age under 75, left main stenting versus CABG. And what you see here for the younger patients, it's very clear CABG is the better treatment option. It's less clear, though, in the elderly. Curves are about the same. Of course, not large numbers here, about 400 patients or so altogether. And when you look at mortality, actually here in the younger, no difference here, but the elderly, it looks about the same. And if you looked at the cardiac adjusted mortality, it actually trended in favor of the left main stenting, interestingly enough. But this is non-randomized, and obviously we have to be careful with that. What about registries and the burden of disease? Well, it is interesting. This largest data set comes from CJ Park in Korea once again. 1,100 patients or so treated, low score, intermediate score, high score, and you can see for mortality, it really does make a difference. If you're a high-risk patient, you should really have coronary artery bypass grafting and in this series. So it's consistent with the randomized trial. Now, what does the guidelines say? Just published about 1.5 years ago. Important aspect here is the heart team, and I think we do very well here. The surgeons are very keen to work closely with us on this. Where we may not be working so closely is on defining the STS score and the Syntax score, but both of these are actually recommended approaches for complex coronary disease or left main disease. On top here, and I'm not going to bore you with the details, are the US guidelines, and just for comparison at the bottom are the European guidelines for PCI of left main disease. Pretty much it is a approved use of this, recommended, not a class 1 but a class 2A, could be used or could be considered a class 2B. Same thing in the European guidelines for milder forms of disease. But the major difference lies in these high-risk patients with left main lesions that have PCI with a high score. It is a class 3, should not be done in the US, but it actually is, could be considered in the European guidelines. So a little interesting difference between the two guidelines looking at the same data. Manesh Patel, thank God, published these appropriateness criteria because I was worried that I will do mostly inappropriate PCI in the cath lab, but it turns out that actually it is uncertain based on the appropriateness criteria if you should do left main PCI or left main with some other lower risk disease. For the high risk, it's deemed inappropriate, however. Now finally, how we're going to expand the horizons for patients with complex disease. Well, David Kong is the PI for the Excel trial in this here at Duke. He just randomized the first patient last week to an unprotected left main. The patient was randomized to PCI, but this is a randomized trial of PCI versus CABG using a new drug-eluting stent. 2,600 patients, all low Syntax score, all discussed with the heart team, and Shu Lin is our heart surgeon that works with us on this. It's a non-inferiority trial as a primarily set up, but it can also test superiority. You can see the event rates here, 11% in each arm, roughly 7% or so for PCI is projected. Then the study would have 80% power to detect the difference. Here is the syntax score, now the low syntax score, just to remind you again, the left main disease patients only. You can see fairly comparable, so I think it's reasonable to randomize them. Numerically, actually, lower mortality with PCI here, but this is a subset of a subset. So I think it's a reasonable thing to do. You should remember that this stent, the Science or the Promo stent that is used in the trial, is actually in blue significantly better than the Taxus stent that was the predominant stent in many of the other trials. So there's a little bit of enhancement there possible. And then looking at the antiplatelet therapy, this is just reported from TCT a few months ago. It looks like prasugrel in this adjusted analysis is superior to clopidogrel, and of course we have prasugrel available to us. So there may be other things that may actually improve outcomes further for patients undergoing left main PCI. As of a couple of weeks ago, Greg Stone shared with me about a little bit less than half the patients have been enrolled, 140 sites, 17 countries in this trial. So now to the final case. This is a 86-year-old man from Danville, Virginia, presents with shortness of breath, class 3, on home oxygen, severe COPD. FEV1 is 35% of predicted. He has a history of diabetes, sleep apnea, and the history of CABG, 2 vessels, all veins, done 2005 in Virginia. He undergoes a cardiac catheterization in Danville, found to have a left main of 90%, osteal-LAD of 60, insignificant disease in the circumflex and RCA, and his vein grafts are all occluded. In addition to this, he has aortic stenosis with diastolic heart failure, EF of 45%, peak velocity 4.1 meters per second, peak gradient 66 millimeters of mercury, and valve area 0.6. So he's seen and discussed by the heart team, Kerry Ward, Kevin Harrison, Chad Hughes, Carmel Milano, myself, and this is the summary. He's not a surgical candidate because of COPD and redo, very high risk. He's a potential TAVR candidate, but he has significant coronary disease that precludes him for this. He is a potential left main PCI candidate, but he's extreme risk because hemodynamic compromise in people with aortic stenosis is very hard to manage. And so these options are discussed with him, and he agrees to a staged percutaneous therapy all the way around. So patient and family agrees to left main PCI with prophylactic balloon pump support, no surgical backup. This is to be followed by TAVR if successful. PCI is performed on bivalirudin, aspirin, and clopidogrel with balloon pump for 4 hours. A drug-eluting stent is placed. You can see the parameters here, and IVUS is used. Here is the pre-lesion here. You can see it fairly clearly. This is stenting into the LAD. And you can also see the balloon pump here in place. This is the IVUS pre. You see the area is 3.9, so it's a very significant lesion. This is area afterwards. It's almost twice as big post, which would actually indicate a good result. And then the TVR is performed in the core valve extreme risk registry 3 months later. He gets a percutaneous balloon valvuloplasty followed by placement of a 29 millimeter core valve by Kevin Harrison and Chad Hughes. Coronary angiogram during this procedure shows patent left main stent. He's discharged home 5 days later. He has some heart failure, which is mild. Here is his placement or measurement for placement of the TAVR. Here you can see the stent in the left main, the valvuloplasty done on the right-hand side. And here is the partial opening of the device, the TAVR. You can see some dye filling the left main there. And here's the device fully deployed away from the left main stent that incidentally is not hanging out into the aorta because we used IVUS to define exactly where to deliver it. He's now home. He's actually alive 6 months later. Quality of life much improved, uses less home oxygen, and diastolic heart failure gradually improving. Unfortunately, he hopes that UVA will beat Duke this year in basketball. We couldn't convince him of that. So in summary, PCI for left main is still a high-risk procedure and most complex to treat. The tools for left main is vastly improved, and the hemodynamic support offer a real safety profile here. Left main PCI have become more mainstream, but it still need more randomized data for it to be really used on a more regular basis. Left main PCI and chronic total occlusions are the two last areas slowing us down from an all-percutaneous approach to CAD. Now, valves are next, as you know. Still no surgeons here. Good. So I have to say I have really enjoyed working on left main. It's been a real interest of mine, as many of you know, and it's a lot of fun. It really is fun. It may not seem like that, but it's a lot of fun. And here's another fellow who has a lot of fun. So you got to have fun at work. So thank you very much for your attention.